Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and welcome to Attitude Magazine's ADHD Experts Broadcast. We're very pleased to have Nicole Brown here, Dr. Nicole Brown, here to talk about childhood trauma and its relationship to ADHD. Before we get started, let me note a couple of housekeeping items. Those of you tuned in to the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you are interested in the Certificate of Attendance option, look for instructions in the email you'll receive about an hour after the live broadcast. For those of you listening in replay or podcast mode, please visit the webinar replay page on the Attitude website, www.attitudemag.com/podcast-328 for access to both the accompanying slides and the Certificate of Attendance option. Also, today's sponsor is Play Attention, Enhancing Brain Health and Performance. For over 25 years, Play Attention has been helping children and adults thrive and succeed. Their NASA-inspired technology and cognitive exercises improve executive function. The program includes a lifetime membership and a personal executive function coach to customize a plan along the way. Tell them the areas you want to improve, and they will create a customized neurocognitive training plan to help you achieve those goals. Click on the hyperlink on the screen for a free consultation or call 800-788-6786 or go to their website, www.playattention.com. You can use coupon code ADDMAG1020 to receive $200 off a Play Attention program. Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. Now for today's topic. Children who have experienced trauma are at significantly higher risk for an ADHD diagnosis and moderate to severe ADHD symptoms. Many of the symptoms of traumatic stress overlap with symptoms of ADHD, posing diagnostic challenges for lots of clinicians. Although adverse child experiences, they're called ACEs, A-C-E-S, are reported across all racial, ethnic, and socioeconomic groups, specific types of trauma, such as racial discrimination, are uniquely experienced by children of color and may potentially affect ADHD diagnosis and treatment. Pediatricians and other primary healthcare providers do not systematically identify adverse childhood experiences in practice settings or routinely screen for them during ADHD evaluations, increasing the risk of misattributing trauma symptoms as ADHD. Dr. Nicole Brown is here to help us sort through all of this. Dr. Brown is a general pediatrician and health services researcher, and is the Chief Health Officer of Strong Children Wellness, a new pediatric primary care practice network that reverse integrates comprehensive pediatric care into existing child and family serving behavioral health and social service organizations. Dr. Brown formerly served as assistant professor in the Division of Academic General Pediatrics at the Children's Hospital at Montefiore, Albert Einstein College of Medicine. You can ask questions of Dr. Brown during her presentation, and we will try to get to as many of them as we can after she finishes. That all being said, I'll turn it over to Dr. Brown. Thanks so much for being here today. It's a pleasure.
Thank you so much for that introduction and for the invitation to speak to you about this topic today. So I wanted to start by putting some of what I'm going to be talking about into context, and by sharing how I first became interested in this area. So when I was a pediatric resident in Baltimore, I took care of a 9-year-old boy and I'll call him Joshua. It's not his real name. And this photo is a representation, not the actual patient. And Joshua came to me after 2 years of not receiving any medical care. He had already come to me with a diagnosis of ADHD, and he also had a co-occurring diagnosis of conduct disorder. His primary caregiver was his 69-year-old grandmother, and she herself had a number of chronic ailments, including poorly controlled diabetes. She was largely confined to a wheelchair and was taking care of Joshua and his 3 other siblings. And over time, I learned some pretty disturbing things about Joshua. I learned that his father had been incarcerated for pretty much all of his life. His mother was struggling with some serious substance abuse issues. And Joshua's grandmother would describe his behavior as quote unquote off the chains. He was really, really hard to manage at home and at school. And grandma said that, they tried everything, therapy, various medications for his ADHD. And according to her, nothing seemed to work. And I knew that, Joshua lived in one of the poorest, most violent neighborhoods in Baltimore. And I knew that these traumas that he experienced played a large part in the behavior that he was exhibiting at home and at school. And so I began to look at the science behind how trauma impacts children with ADHD and other behavioral issues. So what do we know about ADHD? We know that it's the most common neurodevelopmental disorder of childhood, and that it's a brain-based neurobiological disorder. Brain imaging studies show smaller volumes in specific brain regions, such as the frontal lobe, the amygdala, the hippocampus, which is responsible for memory, and also impaired activity in certain neurotransmitters. Studies also show a very strong genetic/hereditary component. And we know, of course, that ADHD symptoms are characterized by inattention and or impulsivity and hyperactivity, and that these symptoms significantly impact children's behavior and their performance at school or for those older at work. So there are multiple risk factors that science has shown to be associated with ADHD. These include premature birth, low birth weight, genetic factors, environmental toxins such as high lead levels, traumatic brain injury, substance use, like use of alcohol, for example, during pregnancy. And then there's the environment, the child's environment, the family environment. And I particularly want to focus on what we know about the role of traumatic stress. And so let's briefly review what we know happens to someone who is confronted with an acute adverse stressor. So the body releases adrenaline, which triggers what's known as the fight or flight response. Your hypothalamic pituitary adrenal axis releases cortisol, and cortisol is a stress hormone that actually helps to mobilize the body's energy stores. It activates the immune system. And for brief periods during this fight or flight, it actually helps to enhance memory. And, the good news is that when these stress response systems are activated in kids, in the context of supportive adult relationships, these physiological effects of adversity and the stress response are actually protected or buffered. But when the stress response is long-lasting and these buffering relationships are unavailable, they result in what's known as toxic stress. And toxic stress refers to frequent or prolonged activation of the body stress management system. Studies indicate that toxic stress can have an adverse impact on brain architecture, especially during those early sensitive periods of brain development. Regions of the brain involved in fear, anxiety, and impulsive responses may overproduce neural connections, while areas dedicated to reasoning, planning, and behavioral control may actually produce fewer neural connections. And this may lead to what we term maladaptive behavioral responses, such as ADHD and other conditions such as anxiety and depression. So if you remember, there are also areas of the brain affected by trauma, and toxic levels of stress, like I said, actually rewire brain connections. And over time, this can cause the neurons in your brain to die, and particularly in the prefrontal cortex, that area of the brain that's responsible for executive functioning, for things like organizing and planning, that's responsible for self-regulation and for keeping attention. And then it can also affect the limbic system, which consists of the amygdala and the hippocampus. And the amygdala is responsible for regulating emotions, largely responsible for that fight or flight response that I talked about, and the hippocampus for learning and for memory. So one way to understand how traumatic stress impacts ADHD and overall mental and physical health is to look at the science behind adverse childhood experiences, otherwise known as ACEs. So what are they? ACEs are generally described as stressful or traumatic events that include things like abuse, neglect, and other household dysfunction occurring before the age of 18 years. And these have adverse effects on physical, social, and emotional well-being. This triangle, this image that you see on the right, is sort of how ACEs has been conceptualized by the Centers for Disease Control. And you can see, and I'll talk about this in the next few slides, that as ACEs accumulate, they adversely impact everything from social, emotional, and cognitive functioning. They increase the risk of high-risk health behaviors. And then, as they accumulate, the worst absolute outcome that they've been associated with is early death. So Dr. Vincent Felitti and his colleagues at the CDC examined ACEs recalled by more than 17,000 adult patients seen at Kaiser Permanente Medical System in California. And their objective was to understand the relationship between child adversity and adult health outcomes. And so they distributed a 10-item questionnaire. This was done in the mid-1990s. And they assessed 3 domains of exposure to childhood adversities: abuse, such as psychological, physical, and sexual abuse; household dysfunction, and that included substance abuse, mental illness, domestic violence, what they termed criminal behavior, divorce, and then neglect, which included emotional and physical neglect. Every positive response was given a score of 1. And their findings were quite striking. What they found was that more than 50% of adults reported at least one adverse childhood experience, and more than a quarter reported 2 or more ACEs. And they found that as the respondents' ACE score increased, their chance of participating in risk behaviors and of some of the most common chronic diseases that we see in this country also increased. So, for example, for depression, they found that those adults with 4 or more ACEs had almost a 5-fold risk of depression compared to those with no ACEs. And those with who ever attempted suicide had a 12-fold risk if they had 4 or more ACEs compared to no ACEs. They found the same for some of the chronic physical health conditions that we see. So heart disease and stroke, those with 4 or more ACEs had more than a 2-fold risk of having these conditions. And chronic emphysema and bronchitis, almost a 4-fold risk if you had 4 or more ACEs. What do we know about adverse childhood experiences in children in this country? We know, just like in adults, that they're very common. So children, 48% of children in a recent national survey, their parents reported that those children experienced 1 or more ACEs, 23% 2 or more ACEs. And in the figure on the right, you can see the distribution of what those adversities look like in children in this country, with economic hardship or poverty being the most commonly reported ACE, followed by divorce, substance abuse, neighborhood violence, parental mental illness, domestic violence, incarceration, racial discrimination, and then finally the death of a caregiver. And so when I went to the literature, after I saw Joshua and other children like him, I was actually surprised to see how little there was studied and published about how these adverse childhood experiences impact children with ADHD. And so myself and some other colleagues conducted a study of this same national survey. It's called the National Survey of Children's Health. And we studied over 60,000 US children. And what we found was actually not surprising based on my anecdotal experience, but it confirmed some of the hypotheses I was forming. We found that across every ACE type, children with ADHD, represented by the blue bars, had higher rates of each ACE compared to children without ADHD, which are represented by the red bars. When we looked at associations between specific ACE types, a child's ACE score, and their risk for having an ADHD diagnosis, we saw that among ACE types, that a child who lived in poverty, came from a household where parents divorced, lived with a caregiver who had a mental illness, lived in violent neighborhoods, or had a parent who was incarcerated, were at significantly higher likelihood of having an ADHD diagnosis. We also saw what we termed a dose-response effect between ACE score and having an ADHD diagnosis. That is, as you go up in ACE score, your risk for having ADHD also concomitantly went up. And we saw the same thing when looking at parent report of moderate to severe ADHD. So in terms of the ACE types that were associated with having moderate to severe ADHD symptoms, we found that living in poverty and having a caregiver with a mental illness increased your odds significantly of having moderate to severe ADHD. And we also found that same trend toward a dose-response relationship for ACE score, so that as your ACE score went up, your odds of having moderate to severe ADHD went up as well. One thing to note, and this is true of our study and of a lot of the studies that have looked at the impact of ACEs on health, is that many of these studies are cross-sectional. So they just offer a snapshot in time. The study that I did and many other ACEs studies, it can't actually measure the timing of when these ACEs occurred, the duration of the trauma, or the severity of the adverse experiences. And remember that each adversity is weighted equally. They're given a score of 1. And we know that in reality, some traumas are much more impactful on kids than others. And then finally, having a history of adverse childhood experiences isn't diagnostic of having trauma. So ACEs are past traumatic events. They don't necessarily mean that there's a current experience of trauma. Oftentimes they do, but it's something to consider. So in part because traumatic stress and ADHD affect the same areas of the brain, there is an overlap in symptoms. And children who experience traumatic stress also have difficulty concentrating and learning in school. They're also easily distracted and often don't seem to listen. They can be disorganized, show hyperactivity. They can be restless and have difficulty sleeping. These are the same symptoms that you see in children with ADHD. And this overlap actually complicates ADHD assessment. Trauma can make children feel agitated, troubled, nervous, and on high alert. And these symptoms can be mistaken by the teacher at school, by, parents, and by a clinician evaluating the child as ADHD. Inattention in children with trauma symptoms may actually be them disassociating, or the result of them avoiding trauma reminders. And this can look like a lack of focus, which is a hallmark symptom of ADHD. Intrusive thoughts or memories of the trauma might lead to confused or agitated behavior, which can resemble impulsive symptoms. And finally, ADHD and child traumatic stress frequently co-occur with other conditions such as depression, anxiety, and learning disabilities, which makes it that much harder to tease it all apart. But I think it's really important to note some real differences despite the symptom overlap. So when we look at post-traumatic stress disorder and compare it to ADHD, it's important to note that the majority of children exposed to trauma actually don't meet criteria for PTSD, but PTSD is the result of a traumatic event that causes brain changes, while ADHD is widely considered a condition that, you're born with, and that there are real brain changes, including what I described earlier, smaller, less developed, and less active areas of the brain. PTSD involves 3 primary processes, including re-experiencing the trauma, avoidant behavior, and hypervigilant behavior, while we know that ADHD results in deficits in sustained attention, behavioral inhibition, and regulation. And PTSD essentially causes physiologic, cognitive, and emotional changes in how a person processes stressors, while ADHD, the hallmark, is pervasive symptoms of inattention, hyperactivity, impulsivity that cause significant functional limitations. But traumatic stress can worsen ADHD symptoms. And what we know from the literature that's out there is that between 10 to 17% of trauma-exposed children meet ADHD criteria. We know that having each, the co-occurrence of each, actually worsens the effect of the other. We talked about the impact of trauma on specific brain regions, and that impact actually increases the inattention, the impulsivity, and the hyperactivity. It increases the social difficulties that you often see in a child with ADHD. And then the learning difficulties and the symptoms of common co-occurring disorders such as depression, anxiety, and conduct disorder are worse with exposure to traumatic stress. ADHD itself, having a diagnosis of ADHD, the science has found that that also increases risk for trauma exposure. So children with ADHD, because they're at heightened risk of having interpersonal and self-regulatory problems, they're at higher risk of substance abuse and having other co-occurring mental health disorders. This actually may predispose them to trauma exposure. And studies have found that children with ADHD have higher rates of child maltreatment or higher rates of accidental traumas. It's really important to note, particularly if you're someone who cares for, provides primary care or clinical care to a child with ADHD, that children of color experience unique traumatic stressors that may worsen ADHD symptoms. So, there's been a lot of attention in the media of late on the impact of systemic and structural racism on stress in kids. And the studies behind that are strong. They actually show a sustained toxic stress response in children who experience microaggressions and persistent racism. The children of color are also at increased risk of living in what's called concentrated poverty. And we've seen, in the study that I did and in others, that poverty increases risk for toxic stress. It's one of those ACEs that has been tied to moderate to severe ADHD, as well as having an ADHD diagnosis. So all of this to say that when a child is being assessed for ADHD, the clinician really should be taking a very thorough psychosocial history. And the standard screening tools that we use, I'm a pediatrician, and we typically use the Vanderbilt tool for screening for ADHD symptoms. They don't typically systematically identify those family environment factors, such as adversity, adverse childhood experiences, and other high-risk behaviors that may cause traumatic stress and symptoms that look like ADHD. One study that was recently published showed that only 2% of pediatricians in this country report routinely asking about adverse childhood experiences. And so if we're not asking, there's a chance that we may be missing these factors that play a role in potentially worsening ADHD symptoms or that look a lot like ADHD, and it's actually traumatic stress. So we really should consider assessing for traumatic events and the time that they occurred while we're doing our diagnostic or our assessments for ADHD. There are a range of trauma screening modalities available. The National Center for Child Traumatic Stress lists a number of different trauma screens that clinicians use. And it's also important to assess the child's strengths, their sources of support. These are all things that can build their capacity for resilience and can be leveraged when you're managing ADHD, traumatic stress, or both as a clinician. And also, again, really important to gather information from a variety of perspectives: parents, the child, if that's appropriate, the school, other people in that child's life that can give a perspective and a picture of their psychosocial history and needs. I mentioned sort of building resilience, and we know what the protective factors are that actually buffer the effects of trauma and toxic stress. So things like a supportive family environment and social networks, concrete support for basic needs, nurturing parenting skills. For those living in poverty, we know how powerful of a toxic stressor poverty is. Figuring out how to optimize access to parental employment and education, adequate housing, access to appropriate healthcare and social services. These are all have been shown in study after study to be powerful protective factors that potentially buffer the effects of trauma and toxic stress. The figure on the left I always take a sort of a systems approach to thinking about how we can improve what we do in our health system to buffer the effects of trauma. And in addition to delivering what's called trauma-informed care, which I'll talk about, really making our systems more integrated, partnering with schools and community-based organizations, integrating mental health into primary care or primary care into mental health, which is what my practice does, offering care coordination and wraparound support to children and families. All of those things are really important shifts that our healthcare system needs to continue to make. So what are the implications for treatment for a child that has an ADHD diagnosis or undergoing ADHD assessment and who has also experienced traumatic stress? Well, we know what the gold standard for treatment of ADHD is. We know that it's medication in conjunction with regular monitoring by a psychiatrist or a primary care provider, in conjunction with behavioral therapy and counseling, educational supports and program modifications, and parent training classes and programs that help parents address the challenging behaviors of ADHD. For traumatic stress, gold standard for treatment is psychotherapy, including trauma-focused cognitive behavioral therapy. Promoting safety and building routines and rituals is extremely important for a child who's been exposed to trauma and experiencing traumatic stress. And then stress management and relaxation skills to help cope with trauma, reminders, and distress have been shown in a number of studies to be effective. For the child that has co-occurring ADHD and traumatic stress, the clinician has to use their judgment on the use of medications. There have been some studies that show that those with PTSD symptoms may do a little bit worse on stimulant medications. But I'm not a psychiatrist, I'm a pediatrician, but studies definitely say clinician judgment should be used here. And then, the use of psychotherapy again, including trauma-focused cognitive behavioral therapy. There's emerging science behind the power of relaxation, mindfulness strategies as adjunctive treatment for children and adults with ADHD. And we, of course, know that has shown positive impact for children who experience trauma. And then I mentioned trauma-informed care, and I think that's a really important part of care delivery. And what that is, there are 4 R's associated with trauma-informed care. It's a good way to think about it. But, for those who care for children with ADHD and other mental health conditions, it's important to realize and educate staff, yourselves, about the widespread impact of trauma and understand potential paths for recovery, to recognize the signs and symptoms of trauma in families, in children, and in staff and others involved in the systems that you're working with, and to respond by fully integrating knowledge about trauma into policies, procedures, and practices. And then finally, to recognize the impact of what's termed vicarious trauma. So, caring for a child who's been traumatized, it's hard not to internalize that, as hard as providers try not to. And so recognizing sort of the signs of vicarious trauma in yourself, resisting re-traumatization of children and adults when they do come into practices, by asking certain questions, by doing certain things in a physical exam, for example. Those things are important. I also just wanted to highlight that there are some childhood traumatic experiences that often go unrecognized in children with ADHD. So the traditional ACEs questionnaire actually didn't ask questions about death of a caregiver. That's a real trauma that, can impact ADHD symptoms. And then at the neighborhood and community levels, I mentioned the impact of community violence. That's not asked in the typical ACEs questionnaire. And we have to remember that the original ACEs study was done in a largely homogenous sample, mostly white, mostly adults. And so the ACEs that we're queried about don't necessarily capture the lived experience of other racial and ethnic groups or of children. So things like bullying, being hospitalized and experiencing medical trauma is often overlooked and underappreciated. And then we talked about sort of the impact of racial discrimination on potentially on ADHD symptoms. I just want to end by talking about sharing traumatic stresses in your child's life with a trusted provider. Although a lot of primary care providers and others still have a long way to go in sort of routinely asking about trauma symptoms as well as exposure to adversity, we're increasingly recognizing the impact of traumatic stress on physical and mental health outcomes and on development. And so disclosing a history of exposure to trauma to determine if your child might be experiencing traumatic stress, particularly if they're starting to undergo an ADHD assessment. The studies support that this may be an important component of ADHD assessment that we really need to start considering. And getting an appropriate referral to a clinician that really has expertise in trauma screening and treatment is also very important. And I'll end here. Thank you. Thank you very much.
Thanks, Dr. Brown. That was very good. Very good. Shed a lot of light on these complicated issues. Lots of questions. Do girls handle adverse childhood experiences differently than boys? Are there any studies on that?
So it's a good question. I don't think that that's been sort of widely studied. We do know in terms of the distribution of ACEs that it's pretty equal across genders. But we also know that there are gender-specific differences in the way that children handle stress. I think I can speak only from anecdotal experience and not from the science on this, which I from my understanding is thin. But we do know that there are gender differences in the way children handle traumatic stress. I don't know, though, honestly, whether girls handle it differently than boys. There is some science to suggest that stressors are handled differently between genders.
Okay. I mean, the interplay between ADHD and trauma. One parent has asked, does trauma cause ADHD?
So really good question. And the answer is the science doesn't support that. What it supports is that ADHD is sort of a condition that's largely genetic and inherited, that you're born with. And it causes, specific areas of the brain to either be underdeveloped or, I mentioned sort of deficiencies in certain neurotransmitters. Mm-hmm. Trauma exacerbates those because trauma affects those same areas of the brain. It exacerbates ADHD symptoms, but the science is still sort of out on what actually causes ADHD. And, I had put a slide up that shows that there's multiple risks that have been associated with ADHD, trauma being one of those risks. And we know that it definitely exacerbates ADHD symptoms.
Mm-hmm. One parent was curious about whether a child being adopted at 3 years old could constitute an adverse childhood experience.
That's a great question. I think what's important is understanding what life experiences that child may have had in the preceding years before the adoption. If, they were born, for example, to a biological parent who had substance abuse issues, or were born prematurely or low birth weight, those are factors that increase risk for ADHD. If they were born into a very traumatic situation where there were multiple ACE exposures, that also increases risk of developing conditions like ADHD, other developmental issues, and other mental health conditions.
Mm-hmm. A couple of questions about medication. If ADHD symptoms and history of trauma are present, one person is wondering, is medication still a good treatment avenue? You mentioned yes. Is it just the ADHD medications, or do the ADHD medications help with the trauma symptoms? So do you ever go beyond just ADHD medications?
Sure. So the answer to that question is yes. I mentioned that there are other co-occurring conditions that often go along with ADHD, anxiety, depression, and those conditions are often exacerbated by trauma. And so I will definitely take care of children who, are placed on a stimulant medication and also maybe taking an antidepressant or something for those other co-occurring conditions. And I usually co-manage those kids along with a psychiatrist and a therapist. Mm-hmm. And then there was sort of another part to that question, Wayne. My answer may have captured what it was asking, but I think, in general, clinician judgment is really important when thinking about whether to start any medication. Mm-hmm. But, in the child with ADHD and co-occurring trauma, stimulant medications may not be enough. And oftentimes kids with ADHD are entirely managed on medication by a pediatrician or another provider and don't necessarily get that adjunctive behavioral therapy. And it's so, so critical. We know that having both is the gold standard and really is what makes the difference. And particularly if you have both trauma and ADHD, clinicians should use their judgment on starting medicine. And if they do, that child should definitely be getting trauma-focused behavioral therapy as well.
Mm-hmm. Are there practitioners, this is a question I'm wondering about, are there practitioners, should parents look for practitioners who are experienced just in the trauma, ADHD combination? Or would a pediatrician, a general pediatrician, be able to handle both conditions?
To be frank and quite honest, I think, I'm someone who's now 10 years out of training, and that's not a part of pediatric training. While we have gotten adept and more comfortable with managing ADHD and on starting stimulant medications, for kids who have co-occurring trauma or other mental health disorders in addition to ADHD, most pediatricians don't feel comfortable with that management and really need the support of both psychologists and psychiatrists to think through whether additional medication needs to be started and to ensure that child is getting what we call multimodal therapy. So different modes of treatment to really holistically manage all of the issues that may be going on.
Is there an especially sensitive age where children are more subject or more adversely affected by ACEs? Someone is wondering if there's, is it early childhood or does it depend on the individual child?
So it depends on the individual child. We know that when ACEs happen in early childhood, in the absence of buffers, in the absence of those protective kind of effects that I mentioned earlier, that studies have shown that those are the kids who grow up to be adults with at high risk of severe chronic health issues and at risk of early death. But because the brain is so plastic in those early childhood, in that early childhood phase, meaning that the brain can still be molded and shaped and changed, recognizing ACEs early and getting families of young kids the support that they need to prevent more ACEs from occurring and to mitigate the traumatic stresses that they may be experiencing currently is actually really important in preventing any of the bad downstream effects as that young child grows up. So I'd say, early childhood is like the most optimal time to intervene because that's when we can sort of change the trajectory of those brain changes that become permanent in the absence of the buffers that I talked about.
Right. Another parent asks, any connection or research done on the outcomes of adverse childhood experiences and as an adult career success?
Yes. So as a pediatrician, I don't know that literature as well. But what I do know, I'm very much interested in sort of how ACEs kind of have wider impacts on the economy. And there have been a couple of studies that have shown that people who experience adversity earn less, are less likely to sort of find stable positions. So that data exists. It's pretty thin, not many studies from when I was looking at that literature. I don't know if it's changed, but it's data that shows that having ACE exposures increases your risk of later struggling with sort of earning and also finding stable work.
Mm-hmm. I know you specialize in the literature on children and ACEs, but one adult wonders, can ACEs affect adult behavior and emotion negatively, even if their childhood behavior appeared normal? Basically, are there late responses or delayed responses that might affect an adult that wouldn't have affected a child?
Absolutely. I think most of the literature on ACEs has actually been done in adult populations. I think the pediatric literature is catching up. But what I think we're gleaning from the science is that, ACEs cause, sort of changes in the brain and changes in different organ systems over time. And they may kind of declare themselves, those changes, later in life. So, we see that ACEs heightens risk for, depression, suicidal behavior, and other chronic health conditions that are seen in later adulthood. But those sort of organ changes and brain changes were actually occurring during childhood, and they may have just declared themselves much later in life.
Right. Wow. One parent is saying, would you include witnessing a traumatic event, such as a family member near death or losing someone, as an adverse childhood experience?
I would. I think our conception of ACEs is broadening now. The original study asked about these 10 incidents, but don't capture the range of traumas that people experience. And so there's now kind of an explosion of science around what's called expanding the traditional ACEs. And I definitely think the experience of almost losing someone close to you may be just as traumatic as the death of that caregiver or that person that, is close to you. And people sort of internalize and experience traumas in different ways. Right. And I mentioned kind of the limitations of the ACEs studies in that they assign every trauma a score of 1, where each trauma is really sort of experienced and lived very differently for people.
Yes.
So I would say yes. It's a long answer to that question. But
no, that's fine. That's good. It shed a lot of light on. I had the same question. Can you define accidental traumas? Several people have asked that.
Sure. So I think when I included that in a slide. So a traumatic injury, a bad fall, a car accident, those things can cause traumatic brain injury. Both children and adult studies show with ADHD are at higher risk of those accidental traumas. So that's what I meant by that, if they were referring to that in the slide.
Okay. Could you flesh out a little just because parents always want to know what a proper diagnosis for their child would be if they suspect ADHD and trauma? Could you just sort of outline how it would go? You go in and see the pediatrician, maybe the pediatrician refers you to someone else for medication or that would be helpful.
Yeah. So, typically what the process is that the pediatrician is often the first kind of point of contact. And what most pediatricians will do is that if they suspect that the child has ADHD, they'll administer what's called I use something called a Vanderbilt screen. There are other screening tools that are also widely used. And it asks about the core symptoms of ADHD, as well as other symptoms of anxiety, depression. And so the parent, or in some cases, the child, will answer those questions. And if you'll add up kind of the number of positive responses. And if they fall within a certain number, your child stands a strong chance of potentially having an ADHD diagnosis. But I think the astute clinician will do more than just administer a Vanderbilt screen to determine whether or not your child has ADHD or something else is going on. In addition to trauma, there are a lot of other things that mimic ADHD symptoms. So, for example, medical conditions like hyperthyroid disease may look like ADHD. So, the astute doctor will get some blood tests to make sure that there's not another medical condition going on. They'll take a really good family history and ask questions about whether ADHD and other mental health conditions run in the family. And if all of those things together still point to a diagnosis of ADHD, But if that parent also shares a trauma history, that pediatrician or primary care provider really, really should be referring to a behavioral health clinician, a behavioral health provider that can provide that critical therapy that's needed, that can further probe to see if the child is actually experiencing symptoms of traumatic stress and may even be experiencing PTSD-like symptoms. Mm-hmm. So pediatricians, like I mentioned, really should be working hand in hand with behavioral health providers to sort of probe deeply into the child's symptoms that they're exhibiting, to ask really hard but important questions about potential trauma exposures, and then to work collaboratively on defining a really holistic, multimodal treatment plan.
Uh-huh. Can the neural connections that are inhibited or damaged from trauma be rebuilt or strengthened?
Yes, particularly in childhood. And so, therapy is really important in kind of providing protective effects. And those sort of buffers can definitely create an internal environment that's conducive to repair of those connections, really, really leveraging the child's strength and figuring out, what other protective kind of factors can we bring into this child's life to help rebuild those damaged connections are critically important, and it can happen in childhood, particularly in early childhood.
Mm-hmm. More questions about ACEs. Can the simultaneous occurrence or near occurrences of a number of smaller events add up to a trauma?
Absolutely, yes. So, when in the slide where I talked about kind of the limitations of ACEs studies, that those studies that really only look at ACEs in a snapshot in time, mm-hmm. Most of the science doesn't do that, exactly what that person asking the question is suggesting. They don't kind of look at sort of the timing of these adverse events and of the accumulation of, adverse events over time and how that actually impacts the health trajectory of an individual. But what we do know, sort of what we've seen over and over again, is that someone's ACE score, their number of ACEs, is an extremely powerful predictor of poor health. And so absolutely, the number of kind of what you term small ACEs over time, they accumulate and they strongly predict negative health outcomes as a child grows into adulthood.
And one last quick question for a parent who feels a little hopeless here. You say try to deal with the trauma and, the trauma and ADHD in early childhood as soon as you can. She has a teen who feels might need some help experiencing trauma. And she's wondering if 15 to 17 years old is too late to deal with it.
That's a great question. It is absolutely not. And I didn't mean to suggest that if you don't deal with it in early childhood, you'll sort of have kind of permanent effects that can't be helped. It's really, really important to get the help if you see, your teen or, your older sort of adolescent or young adult kind of struggling with traumatic stress and or who also may be exhibiting symptoms of ADHD. The treatment modalities that I spoke about have been shown to be effective in all age groups. including an adult. And so getting the help now is really important and can be effective.
Well, that's good. That's good. Excuse me. The hour's up, and really, thanks so much for being here and sharing your expertise. It really was an excellent presentation, Dr. Brown. I loved it.
Thank you for having me.
Sure. We'll have to have you back on again. So thanks, everyone, for being here, and have a great day.
Thank you.
Take care.
For more Attitude Podcast and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.